introduce yourself with the Zoom chat box, and then folks in the room getting ready soon. So thank you for joining this hybrid event. We're hoping our technology stays with us. And thank you for joining us during the day, during you taking time out of your busy schedule. Maybe one more minute while folks are coming in. And Zoom.
Lisa, you may have seen in the chat, the microphone is not picking up very loudly at your end.
Yeah, thank you. I will be speaking louder and leaning into it once we do that. So we did a sound check, but thank you, Steve. All righty. How is my volume online? Thumbs up? Okay, great. Well, thank you. Good morning, good afternoon, everyone. My name is Lisa Helm. I'm the Executive Director of Core Group, and I have the distinct honor of welcoming you today to our important event on community health in fragile settings, strengthening local systems for humanitarian crises. So as I mentioned before, please start to introduce yourself in the chat, Zoom chat, and tell us where you're zooming in from. And our folks in person in Washington, D.C. will have the opportunity later to network. So I'm zooming in from Washington, D.C., and I'd like to welcome all of you today for joining us online, in person. And I know that there was a lot of interest in this topic. We know that right now, as I'm like looking around the room, I see. Sorry, I'm just going to adjust it. Can you adjust it in the back? Okay. So I'm going to lean in a little bit more because people are saying it's very low. When I'm looking around the room today, I'm reminded about our community, the Core Group community, for 28 years, strong and proud. Core Group embodies that shared experience and the collaboration of practitioners, researchers, and advocates who refuse to accept the status quo in global health and who are working tirelessly to reach the most vulnerable and underserved communities, down to the last mile. Right now, we're meeting at a pivotal point. While many communities are still addressing the impacts from the pandemic and other health emergencies, this past year has forced us to navigate a rapid shifting global health and humanitarian landscape. According to the IMF and World Bank, over 1 billion people are impacted by living in fragile states, and currently over 323 million people are impacted by humanitarian crises and need life-saving intervention. Throughout this shift, one truth remains clear. We must strengthen systems to expand community health practices for underserved populations, especially women, children, and adolescents. Throughout this shift, in my discussions with a lot of our members and the communities that we serve, whether it be in Africa, in Asia, here in the United States, Latin America, we've seen the heavy impact of these crises firsthand. But amidst the challenges, I've also witnessed the incredible resilience, specifically from community health workers. They remain the backbone of our efforts, providing life-saving community outreach, health education, maternal and child health services, nutrition, immunization, community health and based surveillance, rapid outbreak response, and so much more. And as the global health community recalibrates where we are right now, we must do what the community health world does best. We adapt, we innovate, and we integrate. Over the last year, we've moved beyond rhetoric and the rhetoric of localization. Right now, we're practicing. Authentic local leadership is our only path if we hope to address the many growing threats of climate change, wide inequality, and protracted humanitarian emergencies. Today, we're joined by a panel of experts in DC and online who carry this mission forward every single day. They'll share real-world examples of their life-saving work performed under the most difficult circumstances. Their efforts don't just tackle today's problems, they build the resilient local systems that we need for tomorrow's crisis. I want to thank our presenters for their leadership and for grounding our discussion in evidence and action. Our main objective for today's event is to spur that action from the conversations we have today and going forward. So thank you, all of you, for your tireless commitment to this mission. And I look forward to the insights that we're going to generate today. But before we get started, I do want to introduce a new member of Core Group online and to our team, our membership coordinator, Tambutsa Magwenze, and you can see her online somewhere. And she joins us from Zimbabwe. In her role, she'll support the Core Group engagement and growth of our global network of community health practitioners and partners, helping to strengthen our collaboration, our knowledge exchange, our participation across our very diverse membership. And we're so happy to have Tom today, or Tom. Thank you, Tom, for joining us today. I'm also grateful for Kate Gabor, Communications and Advocacy Lead for Core Group, who's online, and Dr. Berenkopf, Core Group's Humanitarian Organization Project Manager for the Gavi Zip program. All right, got some better volume there. Thank you for all of the support that they have had putting this event together. Today also marks a milestone for Core Group and for our community. It's the official relaunch of Core Group's Humanitarian Health Working Group. As part of the relaunch, I'd like to introduce the working group co-chairs, Dr. Cecilia Dumaka, who is online, and Dr. Ricardo Eschler is here in person at the front of the table. In addition to our own Dr. Berenkopf, who will support the working group on behalf of the workers. And it's my pleasure to introduce Dr. Cecilia Dumaka, a distinguished medical doctor and humanitarian leader. She joins us online from Nairobi. She brings deep expertise in strengthening health systems across fragile and crisis-affected settings, which she continues in her role for care as senior technical advisor in emergencies. Her career focuses on bridging the gap between emergency response and community anchored recovery. Others newborn announcements. And as co-chair, she'll apply a critical systems lens to ensure that our global evidence translates into direct operation. We're so happy that she's joined us with her leadership, advancing community-driven solutions. And I'm also pleased here in the room with us is Mr. Ricardo Eschler, an infectious disease epidemiologist with over 20 years of experience in global health security, One Health, and emergency response. Most recently, Ricardo led regional health emergency engagement for USAID in East Africa, where he built and strengthened critical partnerships across the continent. His leadership has been instrumental in managing significant global threats, including COVID-19, Ebola, influenza, while bridging the gap between that development and humanitarian action. Having served with USAID, NGOs, and the World Health Organization, he brings a wealth of cross-regional experience to the community. And as a long-standing collaborator with the core group, he now returns as co-chair for the Humanitarian Health Working Group. So I'm just so grateful to both Cecilia and Ricardo for their leadership. The relaunch of this group is so important and vital, and signifies the commitment right now that core group has on bridging the gap with care through collaborative action and turning our collective knowledge for those online, for our members in Africa and Asia, around the world, into steady, reliable life for those living through humanitarian emergencies. The expertise in this community is unmatched, but our impact depends on your active participation. So I urge you to join the working group, to join Cecilia, Ricardo, and Brooke in this mission. Bring your data, bring your challenges, most bring your voice to our upcoming events, our sessions, and action that we're going to take going forward. So thank you very much. And I would like to now bring Ricardo up to moderate the panel and introduce our fabulous speakers. Thank you so much, everyone.
All right, good morning and good afternoon to those joining online, wherever you may be. Thank you for joining us today. I'm honored to moderate this section of today's event. But before we dive into this technical discussion, I just want to thank Lisa and the core team for the support that they have given to us in this group and today's event. Not without your support, so thank you so much. I'm deeply honored to be co-chair along with Dr. Cecilia Mbaka of the relaunched Humanitarian Health Working Group. The core group Humanitarian Health Working Group serves as a bridge between global strategy and local reality. Our mission is to ensure that health systems in humanitarian contexts are not just reactive, but resilient, locally led, community centered. To guide this work, we will focus on 4 strategic pillars. The first is community-based emergency health systems. We recognize that in any crisis, the community, the first responder, is the last responder. We are focused on strengthening these frontline systems so that they can maintain essential services even under extreme pressure. The second is protection and support of frontline community workers. Global health goals rest on the shoulders of community health workers, as you heard Lisa mention. We must advocate for their safety, their mental well-being, and their right to fair compensation and recognition and formal health protection. The third is governance and financing of emergency health systems. Resilience requires sustainable structures. We are examining how to shift financing governments to empower local authority, ensure resources reach last mile effect. And finally, something many of you are probably hearing more and more every day, responsible innovation and artificial intelligence. Innovation is more than just new technology. It is figuring out, finding smarter, more ethical ways to deliver care. This is especially true as we integrate artificial intelligence into our workforce. I mean, people have heard that everywhere. We must ensure that AI is used responsibly, prioritizing data privacy, mitigating algorithmic bias, and ensuring these tools serve to close the equity gap rather than widen. So I'm proud to have today's speakers joining me today who embody these themes in practice. This is the key, is that what you hear today and what the work will be be doing is talking about the practice and action that our members and our partners are doing every day to reach those at the last one. So as we listen to their insights, I encourage you to think about how these themes intersect with your own work. And it's now my pleasure to go over the bios of each of our 5 speakers. We have a great mix of speakers, both here in the room and online, providing country context, global context, and the work that is so critical. So first up, you see me lean in closer. I'm trying to be a little louder for those online. Is Dr. Janet Karimi. Dr. Karimi. Dr. Karimi is a medical doctor and public health specialist with over a decade of experience in reproductive, maternal, newborn, child, and adolescent health service delivery, program implementation. A graduate of the University of Nairobi and Columbia University, she currently leads the reproductive and maternal health section for the Kenyan Ministry of Health. She previously headed the Division of Newborn and Child Health, where she developed key national policies to reduce maternal and infant mortality. Her expertise includes coordinating health sector performance reviews and driving large-scale resource mobilization. As a strategic leader, she builds effective partnerships to champion equitable, high-quality healthcare. Second speaker is Mr. Bernard McCall. Bernard serves as the acting executive director and president of Goal USA, overseeing program design, innovation, and business development. During his decade-long tenure at Goal, he's led regional operations in Latin America and Central America. He's pioneered programs in urban resilience, blue economy, and humanitarian leadership, while authoring key resilience analysis frameworks. Bernard specializes in public-private partnerships, particularly with the water services sector, and he actively advocates for systems thinking to drive sustainable international development. Our next speaker is Mr. Joseph Abore. Joseph is a medical doctor and public health specialist with extensive experience in clinical medicine and global public health practice, with a particular focus on sexual, reproductive, maternal, newborn, and child health. Joseph currently serves as the senior technical director for the Momentum Integrated Health Resilience Global War, a U.S. Department of State funded initiative implemented by Force International and IMA World. In this role, he leads the technical planning and implementation of life-saving maternal, newborn, child health, nutrition, wash interventions across Momentum-supported countries, including the DRC, Niger, Mali, Benin, South Sudan, Bangladesh, Ethiopia. Our fourth speaker is Ms. Sarah Mutalian. Sarah is the Deputy Director of Health at the International Rescue Committee, overseeing health programs across 40 countries. Her work focuses on the delivery of essential health services to communities affected by conflict, displacement, and the climate crisis. With over 25 years of experience in public health, Sarah has held leadership roles in the development and public sectors. She is passionate about strengthening health systems and expanding access to quality community-based care, especially for hard to reach populations. Last but not least, we have Dr. Brooke Fahrenhoff from our own core group team. Dr. Fahrenhoff serves as the Humanitarian Immunization Technical Advisor at the core group, where she supports Gavi's zero-dose immunization project. She recently earned her PhD in International Health from the Hopkins Bloomberg School of Public Health, specializing in vaccine science and policy. Her expertise includes implementation research, epidemiology, and technical advocacy for vaccine equity. Brooke previously conducted research at the Johns Hopkins International Vaccine Access Center to improve vaccine effectiveness. She now applies for dissertation research integrating primary care to reach zero-dose children through the ZIP initiative. So I'm very, very glad to have such incredible speakers today. And we will begin with Dr. Karimi. Dr. Karimi, are you online?
Good evening, everyone. Morning. I hope you can hear me.
Yes, we can hear you loud and clear. Oh, but you're on, yes. And we have Brooke who will advance the slides for you as you speak. So just let her know when to advance the slide. Thank you, Dr. Karimi.
All right, thank you. As introduced, I'm Dr. Janet Karimi from the Ministry of Health, and I'm happy to be here to speak about continuity of essential services during humanitarian crisis. I am unable to see the presentation. Okay, thank you. So we can go to the next slide. So a humanitarian crisis, as many of us know, is a serious disruption to the functioning of a community or a society caused by conflicts, different types of disasters or displacement, which leads to widespread human suffering and overwhelms the capacity of the local system to respond. So it's not only an emergency, but a system failure due to that pressure that ensues from that situation. And in such context, we have health systems which are disrupted or collapse. We have access to health services decline, and women, children, and newborns face disproportionately high risk of death. All right, next. So in terms of maternal and newborn health, humanitarian crises pose such a high threat, and often the first victims are women and children. We have globally 6 in 10 maternal deaths occurring
Dr. Karimi, I think you're on mute.
Sorry. So globally, when we have a humanitarian crisis, it worsens the already bad situation for maternal and newborn mortality. And in a humanitarian setting, we have maternal mortality ratios going up to 5 times higher than in stable settings. And in the newborn setting, we have newborns having 3 times lower odds of survival than those in stable environments. Next. So the health system's disruption goes across different health system building blocks, and this includes damage to health infrastructure, the breakdown of supply chains, the loss and or displacement of healthcare workers, therefore they are not available to provide the services. And all this, the crisis also creates overwhelming demand with limited capacity of the health facility to respond, or the health system, and therefore we have service disruption. So major disruptions occur in antenatal care, in skilled delivery, in offering emergency obstetric and newborn care, and in essential services like immunization and child health services. Next. So how do we ensure continuity of essential services in a humanitarian setting or when we are having this crisis? The first thing is to be prepared or to be aware of the risk of the crisis occurring and to prevent the poor outcomes. So we need to integrate health into the local planning context to ensure that we build primary healthcare systems to be able to bring services closer to the community, to ensure that we have good wash and nutrition services. This will prevent total collapse of systems even in an emergency or humanitarian setting. The second is that during the crisis, we need to ensure continuity of essential services. Therefore, we need to identify either as a country or at subnational level, a minimum initial service package. And this often will include emergency obstetric and newborn care, skilled birth attendants, HIV care, sexual violence response. And this then should, in the planning, be able to be provided even in those humanitarian settings. And then how do we build or back stronger after we recover? So we need to have rapid restoration of services when the crisis is contained. We need to strengthen systems to withstand future shocks, and we need to address inequities. So the lessons we learn from one humanitarian crisis then should inform future planning to prevent such from occurring. Next. So those points I have mentioned, the key strategic pillars are being risk aware, then risk reduction. Risk reduction includes things like integrating risk into health system blocks like infrastructure built to withstand certain shocks, use of solar to withstand issues like electricity outage, use of multisectoral approaches. And then we need to be prepared by developing those minimum initial service packages, emergency plans, and have a surge capacity plan. And then we recover and build back better, be more resilient. Next. So I'll give an example of Kenya, and I think globally for all of us, COVID was one system shocker across all countries, and it disrupted services, which examples of immunization, ANC, and deliveries. And within that time, we might not have been risk aware or immediately had measures to reduce the risk, but this came up. And in Kenya, the Ministry of Health developed interim guidelines on continuity of essential health services during the pandemic. And such responses, early action responses, included allowing movement of healthcare workers. They were given passes, pregnant women did not have any curfew, and there was uptake or increase of outreach services and working in the communities through the community health promoters. Next. So more recently, other examples that we face as Kenya include recurrent drought in the arid and semi-arid lands, that is the ASAL counties. So we've had recurrent droughts, and we've also had areas of conflict and insecurity in those areas also, which affect health worker retention and supply chains. So how do we mitigate this in that setting? So in terms of risk awareness, we are aware of the counties. Counties in Kenya are like the districts or the subnational level administrative regions. So we are aware of which counties are under risk to specific humanitarian crises. For example, the drought and the conflict and insecurity. Therefore, those counties have specific measures or plans to ensure continuity of maternal newborn services and other services, even in that eventuality. Then prevention and reduction of risk, we use our routine monitoring system to look at the numbers, the trends, the coverage, and we are able to detect early where there is decrease in the usual coverage for maternal newborn services. And we map the communities and use our community health promoters to identify, for example, pregnant women, high at risk mothers, and link them to the facilities. So for these communities where we have community health promoters, we know where our mothers are, and in case of risk, then they're able to reach them and guide them accordingly. So in terms of preparedness and early action, there's pre-positioning of essential health commodities at high-risk hotspots, including family planning, diagnostic kits for antenatal care, delivery kits, so that we have maybe more than what is needed in the event, in the case we have an emergency. We also conduct mobile integrated health outreaches in hard-to-reach areas while ensuring minimum service package for reproductive, maternal, newborn, child, and adolescent health services are offered during crises. And in terms of recovery and resilience in some of these affected counties, we engage men and elders to ensure they also are aware of the importance of, having access to healthcare services, even in these times. We also talk to the security personnel on the ground to ensure security for the communities or the persons who need these services. We also they've upgraded health facilities infrastructure where we have solar power backup, water systems, and expanded safe delivery spaces in these regions which face insecurity. Next. We've also had examples of flooding, most recently in 2024, and even this year, actually in March, April, we had cases of flooding where we work together from the Public Health Emergency Operations Center, which is a national center for emergency response for public health emergencies. We activate the incidents management system and team, and specific to that incident, in this case, the flooding, and they work across the key health pillars to ensure that the teams are deployed for case investigation and response is given according to the recommendations that are made. And If it is affecting only one area, one county, then that emergency operation center then is activated, or the one nearest to that county. So this is how response is done in Kenya. It is led nationally, but there are sub-regional emergency operation centers, and the response is both national and with the partners at various levels. Next. So what is the role of ministries of health in health humanitarian action? The core role is coordination and partnerships. It is a multi-stakeholder engagement. One of the key roles is leadership, activating the emergency response team, resource mobilization, ensuring that the health system is strong and resilient, and strengthening especially the primary healthcare system. And also guiding programming, different programming areas, in our case, maternal newborn health, to ensure that our programming also reaches those in those vulnerable contexts, and having mechanisms of continuity together with our partners for that. Next. So some of the challenges we still face, because we do respond, but we could improve our responses. Nationally, we do not have a defined minimum initial services package, though some exist at the subnational level, or where we have refugee camps and those insecure areas. We have suboptimal coordination within the health sector and other ministries and agencies. We have low funding for emergency response, and overall, our staffing gaps for human resources for health is low, and this is one of maybe the greatest challenges that we have. And our priorities, therefore, is to strengthen the National Public Health Institute to detect, manage, and coordinate these public health emergencies, including maternal and newborn health, strengthen multi-sectoral and partner coordination, and put systems in place for resource mobilization strategies to ensure we have funds, even before the emergency occurs, to mitigate that the low access in service utilization or availability. Then we are strengthening our subnational emergency operation center and integrating maternal newborn health into disaster risk reduction strategies. So that is our example from Kenya, and we are happy to learn from the larger community on how to strengthen our emergency responses in humanitarian setting, especially for maternal newborn health. Thank you.
Thank you, Dr. Karimi. We appreciate your presentation from Nairobi. Next up, we have Mr. Bernard McCall. Thank you.
Microphone is muted.
There's no voice.
You can talk, try and see. I turned up the volume.
Is this better for the volume?
I think you can continue, yeah.
It's barely.
No, we can't hear you.
Okay, go ahead. And try it with that one instead.
What's this? Are you able to hear me?
You're whispering.
Your audio changed a little bit.
Brooke, we can't hear you, but we could hear Lisa when she was talking.
So if Bernard went over and used Lisa's microphone.
I'm not having a microphone. I'm in the
I think the mics in the back of the room pick up.
mic's in the chair. Hi everyone, thanks for bearing with that. Yeah, thank you. So go ahead and do another online.
All right, everyone. Sorry about that. We're trying to figure out my situation here in the room. While we do that, we will skip ahead, have Joseph present next, and then we hope that Bernard will then be able to present. So, Kate, thank you so much for advancing the slides, and then we'll come back. Sorry.
Hello. Let me know if you can hear me.
Yes, we can hear you loud.
All right. Thanks so much. We really appreciate the invitation to be a part of this this session today. Yes, my name is Joseph Obure, and I work for Chorus International on the Momentum Integrated Health Resilience. Next slide, please. Next slide. And this will be the outline of what we'll talk about today. Next slide. Next. So I'll talk a little bit on the project that we'll be sharing our work today. I know that this is more of humanitarian group, but we are a development project working in the humanitarian sort of context, bridging, between the humanitarian and development. This is we are on the 6th year of the implementation, which started since May of 2020. We are funded by the Department of State, and the goal of the project is to deliver quality integrated life-saving health, nutrition, and the WASH services, as well as detecting and responding to disease outbreak, with the major aim of reducing maternal, newborn, and child mortality. And at the moment, we work in Mali, Niger, DRC, South Sudan, Sudan, Bangladesh, Ethiopia, Burundi, and in the Philippines. And last year, we closed our work in Tanzania, Benin, Burkina Faso, and Yemen. Next slide. MIHR, or Momentum Integrated Health Resilience Project, is a consortium of organizations led by IMA World Health or Chorus International, and key partners in the consortium are JSI, GOL, USA, CARE, as well as ACHA. And therefore, the work that we will present here is a work of a collective group of these NGOs. Next. Speaking about working in fragile and conflict affected setting, this slide just shows the range of fragility indexed in countries that we work in, ranging from 75 in Philippines up to almost 110 in Sudan. Taking into account that Norway, which has the lowest fragile state index, has just 12. Next. Now, the goal of the project, as I've mentioned here earlier, is to reduce mortality and morbidity in fragile and conflict-affected settings. And then we work through 3 results, with the first result being increased access to and the use of high-quality integrated life-saving health, nutrition, and WASH services. Result number 2 is strengthening of the partnership with local organizations to deliver life-saving services. And then result 3 is improve adaptive management to prevent, detect, and respond to health emergencies. So for all countries that we work with, they use this framework to implement intervention based on the context and needs that they have. Next slide. These slides just show a range of interventions that we provide across the countries that we work in, from maternal, newborn health, and child health, covering from ANC, emergency obstetrics and newborn care, essential newborn care, health, helping baby breathe, PSBI, kangaroo mother care, IMNCI, ICCM. We have nutrition interventions as well for the pregnant women and the lactating women, as well as for newborn and children under 5. We also do vaccination services, from routine immunization as well as during disease outbreak. And you will note that in Philippines, this is the only country that we don't do all other range of activities, except that we are supporting the cold chain. And the last relates to infectious disease outbreak, where we respond in almost all of the countries that we work in. And as we speak now, we have some of the countries with some response that we are addressing. Next. So I'll go straight into the the implementation strategies. And these are strategies really not geared to only community level interventions, but across, from the health facilities to the communities, as well as on the policies. So we try to really contextualize in the
6 of our 12-bed zone.
Excuse me. Okay, I'll go back.
Joseph, you were okay, but now you're on mute.
Okay, good. All right. Yes, so we try to contextualize and making sure that our approach to deliver the services are flexible, providing the services from the health facilities, and also using community-based delivery approaches such as outreach, mobile clinics, and even using campaigns, and making sure that we're able to facilitate, effective referrals and linkages. We also work with the local organizations and community health workers, depending on the country, to make sure that we are able to mobilize and engage the communities to be part of improving the health and outcomes in the community that they live in. And we support making sure that frontline health workers are enabled to do their work. And then we have a partnership which ensure that we are able to deliver during even before and even during the crisis. And also we still make sure that we adopt the tools and standards to ensure that we are able to scale up the life-saving interventions. And also we support community and health facilities for emergency preparedness and planning. Next. So this is sort of the partnership that we have as we deliver these strategies through working with the Ministry of Health, local NGOs, some FBOs, professional associations, other implementing partners, and other humanitarian actors. Next. In terms of the community.
Sorry, this is Ricardo. If you could just start wrapping up. Thank you. Apologies.
Okay, so I'll end with the next 2 slides. So our community health approach is really centered into making sure that we support community health providers, ranging from the community health workers, community midwives, as well as working into the community health post. And another thing is that we make sure that we support the Ministry of Health as well to adapt and implement some of the international standards that would allow the expansion and scale up of the life-saving interventions. The next one. And we also engage the communities to contribute into the advancing of the healthcare deliveries, as well as also we package some life-saving interventions along with other livelihood activities, and also working through the community support group. I have another slide, but if you allow me, otherwise I can stop there and respond to.
Yeah, thanks, Joseph. I think for time we'll have to stop there, but we really appreciate your presentation. Thank you for that. Now, as Lisa mentioned, we have to innovate, adapt, and integrate. So I think, can you hear me now online? Can you give me a thumbs up?
Yes, we can hear your recorder.
Okay, so we'll see. We'll ask Bernard to speak up, and he's taller than me, so he'll have to lean in a little closer.
Hopefully you can hear me okay.
Yes.
Yes.
Yes, we can.
Good.
We're still very much a proud member of the core group. Very happy to see you. So I'll go through my presentation. Hopefully the technology works. This will go through it quickly. So big part of global business is about enabling crisis populations move from health crisis to health resilience. And we'll talk through how we do that around the world and the partnerships that we have in that space.
Bernard, you need to lean into the microphone.
Okay, I'm going to lean in fully. Just as an opening statement, we're going to describe how we frame global health crisis, talk about some of the work that we're doing in program responses to move crisis to resilience, and then just highlight some of the innovations that we're doing. We know there's a lot of innovation happening in the space, but we're happy to share ours, and hopefully that will be of interest. Yeah, so this is how we frame a global health crisis. And one kind of key point of this is that the mega trends are moving things in the wrong direction. Whether it is the increasing threat of infectious disease outbreak, number and scale of outbreaks, conflict, displacement, climate change, environmental degradation, extreme weather events, all of those are pushing an increase rather than a reduction in global health crisis. The way we often define that is unstable, weakened health systems in fragile and conflict-affected contexts is one major consequence of this, and the other is the increasing threat of infectious disease outbreaks. Okay, so goals work in response to this global health crisis is very much centered on infectious disease outbreak response building capacities in that area, and then also stabilizing health systems in crisis. Just a brief overview of what we're doing around the world, responding to health emergencies and enabling communities to overcome health crisis is very much in our DNA. It's our core business. We have a global emergency response team. We have an infectious disease hub based out of Sierra Leone, operations around the world. One that I would call out is in Sudan, largest humanitarian crisis in the world right now. There's a lot of competition for that space. Things have transformed in Sudan over the past number of years. We were working just a short time ago on national health insurance scheme and health system strengthening. Now we're working to support last mile health systems deliver essential services. In Syria is another major program we've been doing for many years, trying to stabilize critical water and health services for about 1 million people every day for 10 years. And there's a massive transformation happening there, hopefully moving to a new phase of stabilization. So that's an example of some of the work that we do around the world with humanitarian partners. We have a lot of experience in rapid outbreak response. We were a major actor in responding to the Ebola crisis. We're all a major actor in responding to the COVID-19 crisis. More recently, the Mpox outbreak in West Africa, which is ongoing even now. Cholera outbreak. Yeah, so I want to talk about innovation. It's an interesting subject to talk about. We'll just highlight 3 areas. It's not a whole lot of time. The first one is really interesting concept around intelligent health. This is a journey that we've been on for about 10 years. Started out in 2016 in trying to understand how people and organizations collaborate to deliver essential services in society. And the most important of those services is health services. We designed an approach for mapping and analyzing that collaboration, and then tools for measuring progress of crisis-affected communities along the trajectory from crisis to resilience. That was the RD Health Toolkit and the Resilience for Social Systems. We talk a lot about health systems. We talk about different types of systems. We talk about the need for systemic change. The word system gets used a lot. We've gone OCD in trying to understand what a system is in mapping out the human collaboration to deliver essential services. So I'm not going to go into detail of this, but on the right-hand side, that is a representation of the collaboration of over 1,000 different types of actors in South Sudan to deliver healthcare services. Much of that is temporary actors delivering humanitarian services, life-saving services, but there's a whole range of permanent actors. And we often have discussions, is there a health system in South Sudan, or have that be questioned on that? There is a system that delivers services, but there's a long way to go to build an independent, resilient health system. And we would always say that the only way that crisis-affected populations can move from crisis to resilience is to protect, stabilize, and strengthen local systems. We've got to understand how the system is functioning currently to do that. On the left-hand side is the overall architecture of the health system and the core transaction chain, supporting functions and rules. We've been doing a lot of work to understand how those systems then can become more resilient, how they'll respond to shocks and stresses. And the next slide is just to open a discussion around how we can take static maps that represent human collaboration to deliver health services and use the opportunity of advanced technology such as AI, blockchain, to create dynamic system maps and create intelligent health systems. Maybe one simple way of understanding this is the app Waze, sort of form of intelligent traffic. How do you use that concept to create intelligent health systems that are more impactful, inclusive, and resilient? So we're doing a lot of work in that space. We've started a pilot in intelligent health in East Africa, in Ethiopia. 1 minute. 1 minute for 2 innovations. Just very quickly on this, we're very much focused on early response systems, health emergencies, and we're working to make them work in place. We think that there's a lot more that needs to be done to engage communities, mobilize last mile health facilities, enable them to identify threats of an outbreak or health emergency, respond more effectively, doing a lot to link communication lines using digital tech solutions from communities up to the levels in health systems and back down as efficient as possible, mapping health systems, linking in climate data into DHIS2 to enable responses to climate threats that would have a health impact. Components of early warning response systems as a framework for all this risk awareness. If you're not aware of the risks, you're not prepared for it. Monitoring and forecast decision making through communication, submission protocols, and response capacity, particularly at the front line. And the last innovation, just to introduce the concept, and I know there's a lot of work happening in this space, using the AI technology to enable communities, populations, health systems, identify the trends of infectious disease outbreak and respond more effectively. There's a lot happening in this space. We're doing a huge amount of work on this to develop tools, which include AI chatbots that go out to communities that are in at-risk areas, advise them of the risks that they're exposed to, give them advice on behaviors, at the same time collect information on the spread of infectious disease, bring that back to the center of operations in the Ministry of Health to enable timely decisions to respond to outbreak. And that's all been done. Everything we do is working with the Ministry of Health in every country. Slight thing, but thank you.
That's what I think. Can you hear me here? Okay.
All right, we're going to try this. Can you give us a thumb?
Can you hear us in the back? If I'm standing in the back room, people online, can you hear us?
Yes, we can.
Okay. All right.
Much better.
Yeah.
All right. Well, thank you so much for that. Thank you, Bernard. Apologies for cutting you and switching the order. We will have 2 more presentations. For those online, if you have questions for the presenters, we will have a short period for a Q&A at the end, time permitting. So please feel free if you have any couple questions, especially if they're cross-cutting questions. Cecilia will be monitoring that along with Kate. Next, we have Sarah from the International Rescue Committee. So Sarah, please, if you can. Thank you.
Thank you. Good afternoon, good evening, good morning, wherever you are. And thank you for having me join this presentation. I don't actually have the slide deck, so I'll speak to my points. As Ricardo's mentioned, I'm with the International Rescue Committee, or the IRC, which has worked in fragile and conflict-affected settings for more than 90 years, and we operate in over 40 countries with a staffing complement of more than 17,000 people, many of whom are national staff and who are embedded in the very communities and populations that we serve. Health constitutes nearly half of our global portfolio, and the context we share is not improving. And indeed, as we all know, 2025 was labeled, for obvious reasons, the worst humanitarian year on record, with just 52% of people in need of life-saving aid being reached last year. The countries on our 2026 emergency watch list account for 86% of unmet needs, and I want to spend my time today sharing what we've learned operationally about delivering in these settings. Our strategic plan, referred to as Strategy 100, is built around impact at scale, which is our commitment to identifying the highest return interventions in humanitarian settings and in humanitarian response and delivering them at meaningful scale through local systems and through local partners. In health, we're leaning in to scale a defined set of interventions with proven health impact and cost efficiency, and I'll just share a couple of examples. Childhood vaccine delivery through our Gavi-funded REACH program has delivered over 30 million doses in conflict settings at under $2 per dose. Simplified malnutrition treatment achieves equivalent outcomes at 21% lower cost, and every dollar spent on contraception saves $2.50 in health costs, with similar accomplishments where IRC works. The mandate that drives impact at scale is not only what works, but the imperative to extend it to the millions that need it is what drives it. A contextual factor in humanitarian work is the nature of government presence, and it was very heartening to listen to Janet's presentation first. As you all know, humanitarian actors work across a very wide spectrum, from settings in which government systems are functional to those where authority is contested or held by de facto actors. The International Committee of the Red Cross estimates that 204 million people now live in areas controlled or contested by armed groups, with 74 million under full armed group control. And in many of these territories and contexts, neither state authorities nor armed groups reliably provide healthcare, and that shapes every level of what I'm about to describe. My remarks today will focus on community-level impacts across a continuum of 4 key roles: last mile delivery, systems support, systems strengthening, and systems change. I'll start first with last mile delivery. Among the nearly 14 million zero-dose children worldwide, 1/2 are estimated to live in fragile and conflict-affected settings, also known as FCAS. Children in FCAS are 3 times more likely to die than those in stable settings, and that's a very sobering statistic. In areas that are controlled or contested by armed groups, it is critical to note that immunization does not happen without negotiated access. REACH, which is the IRC-led Gavi-funded consortium, has built that access across 6 countries: Chad, Nigeria, Ethiopia, Sudan, South Sudan, and Somalia. And when REACH launched first in 2022, only 16% of its target communities were accessible to humanitarian action. And today, we've attained 100%, essentially, achieved through sustained community engagement and negotiated access with de facto authorities and community leaders. Not least, this is significant, particularly as we observe World Immunization Week. Also, in light of last mile delivery, our community-based maternal and newborn care programs in Somalia and South Sudan, we are seeing statistically significant increases in the uptake of essential newborn care behaviors that are associated with commodity and counseling delivery by community health workers, and also where institutional delivery rates fall typically between 25 to 35%, we're filling the gap that cannot be immediately met by facility-based services through community-based service delivery that is critical to reducing preventable maternal and newborn deaths in these settings. So the key lesson is that last mile service delivery in the hardest FCAS context is operationally achievable and cost competitive. The barrier really is sustained investment and negotiated access, and not necessarily always technical capacity. The second role is system support. And as we know, climate resilient WASH is critical to preventing disease and sustaining essential health services in fragile settings where climate shocks are driving water insecurity, displacement, access challenges, and outbreaks. What we need are local service delivery systems that are designed to withstand shocks and continue delivering safe services where the risks are greatest. The IRC delivers integrated community resilient WASH programming in 27 countries, and we've prioritized areas with the highest disease burden and climate risk. In 2024, we reached over 2.3 million people with water services, 1.2 million people with sanitation, and 3.25 million people through hygiene promotion, while strengthening WASH services in over 550 health facilities. Our approach focuses, as mentioned, on locally led, cost-effective service delivery that combines infrastructure, behavior change, and system strengthening to reduce disease risk and build resilience over time. I'll give 2 examples. In Ethiopia's drought-affected lowland communities, IRC is scaling sustainable service models through solar-powered water systems that have been adapted to extreme conditions, and these have replaced diesel-dependent infrastructure, reducing operating costs and improving reliability during prolonged dry periods. Second example is we're in Somalia, where we're advancing predictive, data-driven service delivery through anticipatory action. And through the use of climate forecasts, hydrological modeling, satellite imagery, and vulnerability data, we've been able to identify high-risk locations and trigger early wash and infection prevention interventions ahead of droughts and ahead of floods. And together, this is evidence that these approaches ensure service systems are more resilient and can actually withstand shocks, prevent disruption, and reduce disease risk before crises escalate. And the key lesson here is that system support is essential to building or rehabilitating critical infrastructure. The third role is system strengthening. Our primary healthcare model is built on 4 cross-cutting areas of work that together define how we deliver, sustain, and strengthen primary healthcare in the world's most crisis-affected settings. Firstly, through strengthening community health models for access and continuity of care. And in last-mile settings, we close the service gap by bringing care to the people who cannot actually reach it. And this is done predominantly through community health workers, whom we know are the backbone of primary healthcare settings and programs in the areas that we work in. And they are the platform through which we are able to reach missed populations. Last year, we trained 17,600 community healthcare workers, and we support more than 300 mobile clinics that deliver life-saving care during floods, along migration routes, and in disputed territories where humanitarian access needs to be negotiated. Secondly, we prioritize people-centered integrated care and provide a continuum of services at our health facilities and the areas that we work. So for example, where a child is presenting for immunization, they're also screened for malnutrition. Where a caregiver is presenting a child for malnutrition, they're also offered mental and psychosocial support in the same visit. So we look at and adapt our integrated services according to the context within which they live. And thirdly, we focus on a skilled, empowered, and protected frontline workforce. Health workers are the most critical and most vulnerable element of any fragile health system, and the IRC works to ensure that we're supporting them and positioning them to remain when international actors leave. And we're ensuring also that our presence builds local capacity rather than replacing it. Fourthly, we'll also look at resilient health systems and securing supply chain.
If you could begin wrapping up, apologies.
We look at building resilient health systems, and this is, as Lisa had mentioned in her opening remarks, this is critical to being one of the fundamental pillars of IRC's primary healthcare approach. A final role in the continuum of community level inputs is systems change, and program delivery does not produce impact at scale in communities without the right policy environment and the right engagement at national and federal levels. So where services are endorsed in national health policy and where cadres of health workers are positioned and whether they're recognized is all fundamental to the success and the ability of our organization's ability to reach missed communities. So in closing, I just wanted to come with a direct ask. The organizations that are in this meeting are working in many of the same settings and often with different mandates, but we all work towards the same objective. However, the funding environment has contracted sharply, and the instinct is to compete for space and resources, which is understandable. But however, in isolation, we can't do this. It's a cost that we cannot absorb. And the coalitions that produce shared data and aligned advocacy positions come together more strongly than single organizations can. The IRC is committed to building those structures, and we believe that this working group is one of those places where coalition building can be advanced, and we look forward to the conversation. Thank you for your attention.
Thank you, Sarah. Very much appreciated. Last but not least, we have Brooke, who's now in the back of the room. Hopefully you'll be able to hear Brooke here, who will be our last presenter. Then we'll have Dr. Cecilia Mbaka moderate a quick Q&A. So please, if you have any questions, please do add them to the chat online. Brooke, over to you.
Great, thanks very much. Are you all hearing me well?
It's perfect. We can hear you.
Thank you. Thanks to everybody for their flexibility today. As we worked this out, we wanted to be able to bring together folks in person and online, so we really appreciate that. Great, so as I've been introduced, I'm Brooke Bearcoff, and I work at Core Group as the Humanitarian Immunization Program Manager. Next, please. So today I'll be talking about our work on ZIP, Gabby's Humanitarian Partnership. So I'm grateful that Sarah just introduced this program. Work very closely with Reach on this work. I'll be getting more into the different roles and responsibilities of our team, but Core Group has been brought on to the ZIP project to lead some of the learning, knowledge management, and monitoring work. So I'll be discussing some of our lessons learned and learnings today. Next, please. So for those that don't know, ZIP is Gabby's Humanitarian Partnerships. So ZIP is Gabby's work to really reach children in conflict and crisis settings to deliver full immunization to these children. And this was designed to overcome some of the limitations that we see in traditional Gabby funding that is directed directly to governments. But in areas where governments are unable to operate safely or effectively, these children are being unreached. So this is meeting Gabby's equity imperative to really reach these children in previously missed communities and connect them with vaccination services. We also are at the end of World Immunization Week today, so I'm happy to kind of bring together both our humanitarian perspective here in this room and online, and also be able to celebrate some of the accomplishments of global vaccination this past year. Next, please. So great, ZIP scope. So ZIP works to vaccinate all children 0 to 5 years, and this is through both routine and catch-up schedules. So through routine and immunization and catch-up vaccination to children 1 to 5 years old. As I said, this, ZIP works in missed communities. These have received prolonged immunization gaps and really working to make up some of those needs for several years. And ZIP implementers do a wonderful job at both the supply and demand side, so really filling any role that the NIP would normally play. ZIP is only appropriate in specific contexts. We talked a bit about the conflict and crisis affected setting, but these are areas where national immunization programs are really unable to operate effectively or operate safely. Perhaps this is due to contested governance, ongoing security threats, even government involvement in conflict or marginalized populations. And so ZIP was designed to directly fund NGOs and partners that are able to operate among humanitarian principles and able to work well in these communities. So just to note that ZIP funding is additive to country funding that they receive, so it's additional funding process. Next, please. So as I mentioned, there are many great partners that work on ZIP. ZIP is being implemented by IRC through the REACH program, beginning in late 2022 and continuing through this year, along with CBCHS in Cameroon that began last year. Previously, World Vision had led the Raise for Sahel consortium in the Sahel region. And as I mentioned, Core Group is really bringing some of the learnings and the knowledge management, communication, and advocacy. So we are delighted to work alongside these partners. And while I'm excited to share some of these learnings today, I just want to recognize that it's really the implementing partners who do this work. This is led by IRC, CBCHS, World Vision previously, and just I'm grateful to be able to highlight some of these stories and successes that the local implementing groups have been able to really do. Next, please. Great, so I want to highlight some results. ZIP has been really successful in reaching a lot of children in these settings. We'll go into some of the challenges we faced in just a moment. But overall, ZIP has reached over 3 million children and infants with their first vaccine dose. So putting these children on the pathway to full immunization. A little less than half of these children have been 0-dose children. So these children are those who have not been reached in their first year of routine programming and otherwise would not have been reached had ZIP not been there and there has not been catch-up programming. So these children have been placed on the pathway to full immunization, and we can see that by over 30 million vaccines being delivered by our partners through the course of the project. Next, please. So along with this, ZIP has built on traditional immunization programming and added humanitarian ways of working. So there's 5 main ways we'll get into that ZIP has really been able to meet community needs. Next, please. Great. So ZIP has been able to successfully reach communities through strong access negotiation. As we know, the context in ZIP communities, several communities across the world, is conflict with targeted attacks, presence of organized crime groups, non-state actors. And ZIP's teams have really been successful at negotiating access to ensure safe passage of both community members and health workers. This is continuous capacity building to provide key skills, be able to identify and mitigate risks, and expand operations when safe. If you look at the graph below, you can really see how there's been an increase in scale over time as access has been negotiated. See that it's lower, in the start of 2023, and then expanding as we've been able to negotiate access through mid-2024 and 2025. I do want to note that this does take time to gain access and initiate these services, so it can be a little bit of a slow start in some of these areas. Next. Another key area has really been understanding community histories. We've done this through catch-up vaccination in missed communities. So being able to deliver catch-up vaccination to the 1.4 million zero-dose children. Next, please. We also see this through building trust in communities. IRC and our local partners have done a great job in identifying local partners and delivering services through trusted networks and being able to hire local vaccinators as well. Next. So we also have been able to respond to diverse community needs. We know that in these areas with prolonged service gaps, there are compounded vulnerabilities, there are more urgent needs in humanitarian settings, and our ZIP implementers have really done a great job coordinating with humanitarian partners to deliver integrated packages of services. In Cameroon, this has been a really successful program integrating both nutrition screening and vaccination. Next, please. I think second to last slide, we also deliver for communities by introducing unique approaches that go beyond traditional immunization programming. So this is using approaches like geospatial mapping and human-centered design by global partners such as Think Place and Flowminder, shifting delivery models, introducing new technologies like Indigo, and having increased flexibility. Next, please. This is our last one. And I just want to bring this all together by highlighting a story of Mian Ria. She was born in Sudan in 2021, and she was unable to receive vaccination at the time due to insecurity. Her family then moved to a VA right before REACH began their vaccination efforts. She received her first vaccine dose in April 2024, and by June 2024, following along the catch-up schedule, she was fully immunized right before her 3rd birthday. So a quote by her mother that I really like is, to see the impact of ZIP in this work is, many children in my community did not receive their scheduled vaccine doses due to insecurity and displacement. I am happy that my child is now fully immunized. So next, please, I think that might be it. So yeah, thank you very much.
Thank you, Brooke. Now we'll have our Q&A over to Cecilia. Thank you.
Thank you to all our speakers and to all our participants online and on site. I would like to appreciate our panelists today. I think what we can see very clearly is that crisis is no longer episodic. We see the layering, the complexity of the environments that we do work in. From goal, we've seen the integration of response, system stabilization and innovation. Going to Kenya, we see the reality of anchoring continuity of care within this crisis, and especially for mothers and newborns. From IRC, we've seen the importance of last mile delivery, system strengthening, where systems are weak or absent. Going to the Momentum project that is working across many contexts, we see how they are supporting the maintenance of service delivery in fragile context over time, and finishing with the Gavi zero immunization program. We see how the most vulnerable and missed populations are being reached by these projects. And these are not separate approaches. Today, we wanted to cover the operational realities as a converging model around community-based systems. So going to the questions, I see one question from Judy, so this question is: a number of speakers have pointed out the mortality of infants is incredibly increased in humanitarian systems, considering the cross-cutting importance of breastfeeding as part of a sustainable infant feeding and care. What is the experience of the organizations with integrating breastfeeding counseling into emergency responses? If I can spotlight Sarah, because she did speak to the integration of services within their programs. Sarah, over to you.
Thank you, Judy. That's a great question. Just to go back to the point I was making around integrated service delivery, rather than have, because we are aware of the difficulties and the complexities of providing access, and also for clients to access health facilities, particularly static and mobile services, we try and maximize the capacity of the health system to provide as much of a service delivery as possible. So, for example, we provide, as I mentioned, when a child presents for immunization, they're screened for malnutrition, the caregiver is screened for something else. We integrate reproductive healthcare programs with maternal health programs as well. And that also includes nutrition, and where we provide supplementary feeding programs as well. That is what I made reference to when I mentioned that the child is screened for nutrition. That also includes breastfeeding, a comprehensive package of information and community health advice that is provided by those healthcare providers.
Thank you very much, Sarah. I have a second question, still from Judy. This is for Kenya. I don't know whether Dr. Janet Karemi is still online. So the question is, while USAID was functioning, Kenya was working on improving breastfeeding counseling. Has this capacity strengthening been maintained and reinforced for fragile settings? Dr. Karemi?
Yes, this is still being enforced. Breastfeeding is an integral part of the maternal, infant, young child nutrition programs, which are delivered through both healthcare workers and our community health providers. So we've harmonized our community health worker training modules so that they can reach the mothers at community level. So this is still ongoing. And for Kenya, the government is directly supporting the community health providers in terms of stipends. So despite that stop work order, that community health work is still ongoing, and counties have come in to bridge that gap for community health workers. So we still are continuing with this at both levels. Thank you.
Thank you. So just to spotlight the rest my next question is going to go to Dr. Joseph Obure and Bernard Mako. From the different perspectives from your presentation, we've seen what holds, what breaks within crisis settings. So as we look ahead, what is the one shift in terms of how we design, fund, and deliver health services in crisis settings that needs to be reinforced so that we can strengthen our community systems for humanitarian crisis response and resilience? Over to you, Dr. Joseph.
And can you hear us if I use this microphone?
Yes, we can. Perfect.
Okay, great, because there might be some responses from in the room as well as questions from in the room.
Okay, would you please repeat the question a little bit?
And I think Bernard has the answer here too. So here.
Okay, so let me repeat just for Joseph's sake, and then he can speak after Bernard. From your different perspective, Joseph and Bernard, we've had what holds and breaks in crisis settings. And now looking forward, what is the one shift in how we design, fund, and deliver health services that is most needed to strengthen community level systems in crisis settings?
Oh, okay. So, is Bernard ready to respond?
Yes, yes.
Yeah, because we work together and he may have the same answer. Okay, Bernard.
Yeah, there's probably different kind of components to this, but the most significant thing, from my perspective, is that for a long time, working in conflict, crisis-affected context, the assumption was that you couldn't work through the local systems, and it was an acute humanitarian crisis, and you would prioritize direct life-saving interventions. I think there's a major change that's happening and that needs to happen to recognize that we do need to work through local systems in fragile contexts. How we do that is very different to how we would do it in a more stable context. And there's a lot more that we can do to protect local systems in fragile contexts, to understand how to stabilize local systems. And that will fundamentally change the way we work and how we fund interventions to deliver life-saving services in fragile contexts. So I would say that's the most significant change that's happening.
Thank you. Lisa, are there any questions from the room?
Are there any questions for that folks want to answer in the room to any of the speakers? I know there was a lot unpacked there, so sometimes it's hard to get your head around everything. And I was really interested to hear more about the AI that Goal is using. If you don't mind elaborating on that a little bit more, thanks.
Yeah, that's another hugely important concept. That whether we like it or not, new technologies, AI, and others are going to change entirely how we function as societies. There's a huge set of new risks in that, but there's also a huge set of opportunities for leapfrogging health service provision in fragile contexts. We're very focused on this concept of intelligent health, and it could potentially transform health systems in fragile contexts. We're not the only ones working in the space. We work with a number of major tech companies. We are trying to develop a mechanism where we can have dynamic real-time maps of the health system that will enable ministries for health to monitor in real time how their health systems are performing, how funds are invested and deliver impact, and how those systems are modeled and how they will react to health crisis. So I think it's potentially transformative. It sounds futuristic, but if you look at what AI can do now, this is not too far away. I think it's much more of a reality. And so it has the potential to transform how we support health service delivery in fragile contexts.
Yeah, back to you, Cecilia. I know we're getting short on time, so thank you. Oh, wait, sorry, there is one more question. Let me move over here and please introduce yourself.
Hello everyone, my name is Luciano. I work with CARE. To my Kenyan colleagues, habari zenu, jina langu ni Luciano, niliishi katika Kenya kwa miaka mbili. So I was in Kenya for 2 years during the floods, and I'm curious to hear from Sarah, Jeanette, Cecilia, what metrics are being tracked for early identification of pregnancy, because the maternal mortality rates, as we know, in humanitarian settings, they rise. And if I'm just curious to how we're tracking those metrics specifically, and are we seeing an increase in identifying mothers early? Are we seeing decreases in those numbers?
Would you like to take that, Jeanette?
early detection of pregnant women. Well, we are trying to institutionalize the early ANC attendance. So we started monitoring, I think, last year, no, the year before, the first ANC attendance below 12 weeks, below 13 weeks. So we have that as a measure of early detection of pregnancy. The coverage is not yet high, but it is a start in terms of we have a way to measure that. And then number two, it's only working through, again, the community health promoters that we are able to detect them early and send them to the clinic. We have seen an increase in the skilled birth attendance over time and also the fourth ANC coverage, but the increase is not at the pace we would want it to be, but we are putting in place mechanisms, including a rapid response initiative to create awareness for that and bring this awareness, especially to the community health promoters for early pregnancy detection. Thank you.
Thank you, everyone. I see we are right above the hour,
Yeah.
so I will hand over to Lisa.
Yeah, thank you very much. I
Lisa.
know you can't see me maybe, but you can hear me. So thank you very much for all of the presenters, to Ricardo, Cecilia, to Brooke, to our board members that came, Caroline and Stephen, to our volunteer Zara, who is my daughter, who has helped us a lot, Kate and Tambu, we really appreciate it. This was an important event just to launch the conversation on the humanitarian health and crisis in fragile states, using these community-based approaches. And in every single presentation, what did we keep hearing? Community health workers, and the coordination with the ministries of health. So this working group will be action-oriented and also thrive on that collaboration in learning piece so that things can be scaled, new approaches can be adapted, and probably have special subjects that people are interested in moving forward, especially as Ricardo mentioned, the 4 objectives. So stay in touch. The slides will be distributed, and there is a humanitarian listserv that you can sign up on our website. For those in the room, I think lunch will be getting set up in a moment. Thank you so much for joining us, and have a great rest of your day.
Thank you. Bye-bye.
Thank you.
Thank you.
Well, thank you, everybody. We'll close.
Hi, Kate.
Hi, Tambu. Okay. I think everybody is trickling out.
I know, right? Yeah, yeah. Yeah, at least it's done now.
Yeah.
I know, right? Yeah, no, it's good. Are
It
there
was
anything?
very insightful.
How are you good?
Yes, yes, yes. Let me see if I can remove people.
And the meeting being
Yes.
recorded. Stop the recording.
Yes, let me stop the recording.